Thank you so much, Harshul. It's a pleasure to be with such an august faculty. Since I'll just go over some important points. Some of them have already been covered. No financial interest, but it would be nice to have some. I'll start with the patient who's a 50-year-old lady, business or government contracts, diagnosed to have cataracts at another hospital, came to us with a history of RK done in both eyes about 10 years back with a myopia of -8. And more importantly, in history, her children are doctors and son is a clinical trial specialist. He's done intensive research on types of IOLs and me, and he's read all my papers published. He has a discussion with me on my PCR rates, number of premium IOL surgeries I've done, and son also discusses the average post-op intervals, including the confidence intervals.
Dr. Chawla has one suggestion.
Yeah, just send this patient to your competition.
All right. The doctor also wanted to observe surgery, and we gave the standard pre-op medication. My pre-op medication included prayers to Vishnu, Shiva, and Jesus, because she reads the Bible. And lucky for both me and the patient, the surgery actually went off perfectly. At the end of the day, the hospital was happy with the income, and I was happy with the outcome. In terms of the surgery itself, the RK, just to show you the photographs of the RK mark, and I'll tell you the reason we consider premium IOLs, and it's important if you have had keratoid refractive surgery that just see the RK mark if you're dealing with RK patients, how deep the RK marks are. In this, it was less than about 30%, and that's the reason for the undercorrection. And we could actually safely consider the surgery. Also important that you look at the astigmatism. It's a regular astigmatism on a post-RK patient, and that's another reason you can actually use these premium IOLs. She's of course doing well, and she's followed up almost for about 3 years or after surgery. This is one other patient, and I have some referrals for cornea. And this was an ulcer patient whom we treated. Patient resolved. And I thought I'd done a good job with the keratoplasty after surgery till I saw the topography, and that showed about 6.5 diopters of cylinder. And in these, you're probably looking at the customized range of IOLs, and that's what we actually did for this patient. And also important, though, it's a slightly irregular astigmatism. These topographies you need to take after making sure the tear film is actually very good. Not this patient, but a different patient whom we did customized IOL adapter for about 8. This is a post-therapeutic keratoplasty, about a year and a half post follow-up. In this keratoplasty patient, it's important that we take the incision away from the gaff hole junction. I guess didn't have money as Harshul to actually get those fancy toric markers, so I'm using an old cylinder marker, which is basically made of steel. You mark your incisions. This is according to the plan that was actually sent to us. The phaco is actually quite standard in terms of procedure, and you do a rexus. In just what I did differently was, because it was a slightly hypermature cataract, I did the capsulotomy with the phaco probe just to decompress the lens capsule. Then I complete the rexus with the standard rexus forceps. You can use an MI. I think that would have been a good idea in this patient, and do it, of course, with a lot of viscose in the eye. The cataract is not very hard in these post-therapeutic PKIs because it's an inflammatory cataract. You can actually just aspirate most of the lens out, and it doesn't take too much of time in terms of the phaco power. What was the reason I did opt for this also was because you reduce the phaco power. Remember that most of these keratoplasty patients need to have an endothelial cell count before you actually go ahead and plan these procedures. Also not a bad idea to actually do the pachymetry, because that gives a good indication of the endothelial function. Anything beyond 550, 580, that is definitely a healthy cornea. Anything beyond 650, according to the literature published, is something that you probably need to consider a chance of graft failure. I did make an initial smaller rexus. I then extended it further, and because of the inflammatory membrane, it's a lot more difficult to actually use this. But in a way, when you have a slightly smaller rexus, and I used a plate haptic lens in this patient, it was actually a lot more fixated. It doesn't actually move. As one of the speakers mentioned, if you have a plate haptic lens, the rotation stability is slightly better than a standard C-loop or open C-loop, whatever you call it. I did remark the patient intraoperatively because these markings tend to wash off over a period of time during the surgery itself. and implantation of course standard. In this you have customized toric IOLs, you have options between Rayner and Zeiss available. I'm not sure if the Indian IOLs are customized. The rest of the surgery is of course quite simple. In terms of implantation, I did use viscoelastic because this was a graft patient, and it's important that you protect the endothelium. You might need to even use one whole visco per surgery, but cover these patients with a lot more steroids than you would normally do, because sometimes in a few patients, once you do the cataract surgery, there is an initiation of graft rejection. In this, I prefer, in a plate haptic lens, I prefer to put the haptics onto the iris and just tuck them in, and that's usually the end of surgery. It's easier to slightly twist, but most of these plate haptic lenses have not had issues with rotation post-operatively. We did a small group of study which we had presented at ASCRS last year, where we had group 1 of standard toric IOLs in terms of age, and we also had a group 2 which had some previous cataract surgery. In terms of outcomes, the patients who had standard toric IOL with normal regular astigmatism, the visuals are actually very good. But in a set of patients in our series about 9, the uncorrected vision was actually quite good, which is 612. Remember, in post-keratoplasty patients, for toric IOLs, your thresholds tend to be slightly lower, and you can get about 612 in about majority of the patients, which is very good uncorrected vision. Most of them did do well post-operatively, and none of them actually had a graft rejection. This was spherically put in pre and post. You can make out a bit of hyperopia, which I think in most of these patients is actually quite good. Also in terms of manifest cylinder, a lot of them are less than quarter diopter. In terms of managing patients with previous corneal disease, I think broadly epithelial, stromal and endothelial disease, I think that is important. This 61-year-old patient with arthritis, he had Schirmer's of 1 and breakup time of less than 1. Ocular surface disease is something I do in my dry eye patients, and this was one of these ideal patients. He's a biochemist by profession. He's undergone PI for angle closure, he's been on anti-glaucoma drugs, and then complains of dry eye. And he told me, doctor, whenever I cry, I don't get tears. I said, what's the reason? He says, I've been married for 20 years. So I said, I understand, I've been married for 10 too. And we basically did post-op punctal plugs. We put in the plugs, and you can make out an improvement in the ocular surface. It looks actually quite nice. Important, remember that some of these cataract patients tend to be, of course, on the elder age group. They have borderline ocular surface disease, and it can occur even after uneventful cataract surgery. I know in a busy clinic, not very ideal, but a fluorescence staining and a Schirmer's is a good idea. And if you're working on autoimmune disease and previous dry eye patients, make sure the optical surface is actually very good before you actually go ahead. It's a good idea to give mild surface-acting steroids, topical tear supplements, managing coexisting systemic and ocular disease before you go ahead, and Schirmer's of 5 is good. If you have stromal scars or corneal dystrophy or corneal ectatic disease, you could, in partial stromal thickness scars or leukomas which are peripheral, they will benefit from a cataract surgery alone if it's not in the visual axis. Patients who presented with corneal dystrophy, this one other patient, and cataract, in these patients, toric not a good idea, just do a phacoemulsification and a monofocal IOL. And if you have corneas like this, where the central visibility is actually low, you use basically an endo-illuminator. And a lot of these granular dystrophy patients are about 45, 47, when they tend to get a bit of nuclear sclerosis, do well with a cataract surgery alone in the initial stage. Just a broad outline of how I treat these cases. If you've got a central scar with advanced stromal disease, you can do a sequential or a combined surgery. Sequential as in you do IOL power calculation with the post-keratoplasty eye with all sutures out, as Rajesh mentioned, roughly about 2 months after all the sutures have been removed. It's more predictable, it's about 3 months apart, and the disadvantage being is 2 surgeries, but in private practice it might not be a bad idea. Combined surgery, if you have standard care, you can do it with a single surgery, and it is of course surgeon dependent, and you can need to do an open globe surgery. Sometimes you need to be careful in these eyes. If you got mild to moderate keratoconus with a standard IOL calculation usually suffices. You can take keratometry from the pentacam. I prefer the pentacam. Take into account the posterior corneal astigmatism. We've already discussed that. But in keratoconic eyes, make sure that because there is bowing of the posterior cornea, you need to take the amount of astigmatism in the posterior cornea a lot more into account. In advanced keratoconus, you can just do keratoplasty with the phacoemulsification if there is coexisting cataract. This I think Okay, this is one other patient, a government employee, underwent right eye cataract surgery in 2001. He was referred for some query cornea problem, and we get a lot of unhappy cataract patients in our cornea clinic, unsatisfied with the visual recovery, and there was no retinal pathology, and the best corrected vision was about 6/18. And very, very carefully, the operating surgeon, well done phaco, but he's missed the LASIK flap that the patient had undergone a LASIK about 10 years back. And that was the reason for the defective vision. You do the op scan, you can make out that he has post-LASIK ectasia in both the eyes, the right and the left eyes, and that was the cause for his defective vision, not the earlier necrosclerosis he had in both the eyes. So the suggested treatment at that time was basically to do a collagen cross-link and Intacs. We went ahead for post-LASIK ectasia with collagen cross-linking in both eyes because that was the conventional wisdom at that time, and on follow-up the vision was stable. The plan is now was to basically do a topo-link PRK to regularize the corneal surface, and in the right eye, since he already had cataract surgery, just do glasses and contact lenses. In the left eye, you customize based on the corneal astigmatism and the asphericity which we had access to. This was the Pentacam, and he came in 2013, and I was wiser by that time, as you can make out, and he had corneas like this. And we had a new machine, and in that we could actually do a topo-link. So remember that in a topo-link PRK, you correct the irregular astigmatism by doing an ablation in the irregular part. Now this is the cornea, and the ablation is actually opposite of what the corneal ectasia is. Tends to make the cornea slightly more regular, more spherical. And we had access to high trace. After doing that for one and the right eye, you can make out the cornea in both eyes. The vision is actually doing quite well. He's done a lot better. This is pre-op and post-op regular astigmatism. He will resolve with a contact lens or glass. We did that for both the eyes. In the left eye, we are planning to do a cataract surgery. Remember that in keratoconus and keratoplasty patients, do repeated IOL path calculations, and toric IOL needs to be oriented to the steepest axis. In surgical patients with corneal grafts, important that you do an endothelial cell count. Topography is mandatory. The limbal incision needs to avoid the graft-hole junction. Meticals technique with viscoat, and tend to use slightly lower parameters because it's safer for the endothelium. In conclusion, there are multiple approaches for cataract with patients with corneal disease. Ensure a healthy ocular surface, and you can have multiple options when you're treating these patients. Remember, meditate well before you go ahead. Thank you for your attention.
Thank you very much.